Now, at the request of a much beloved senior member of AAPS, a member since 1949 and past president, who has requested that I simply introduce him by name, I'll honor his request. So please welcome Dr. Curtis Caine.
I want to talk for a couple of minutes about CPAP before CPAP. CPAP, continuous airway positive pressure. This was formalized into a codable entity in the 70s and 80s by a doctor in California and one in Australia. But of course, we've used CPAP for decades. I graduated October 14th, 44, and I retired October 14th, 04, after 60 years. And long before CPAP was called CPAP, I employed it. And so have you and many others. I bring this up because of a very interesting case. On 1/1/54, January the 1st, Dr. Carter O'Farrell in Jackson, Mississippi, called me in consultation to help him with a 24-year-old multipra at term with varicella pneumonia. She had chickenpox pneumonia. Her chest x-ray, which I saw later, looked like someone had covered what ordinarily is dark for lungs with ground glass appearance, just solid white, almost. So you can imagine, here is a young lady at term, diaphragm pushed up, lungs non-functioning, and she died. Dr. O'Farrell called me in consultation. I rushed into the room. It was the 1st of January. I had on, at the party where I was, this Pendleton woolen shirt, 50 years old and more. Got moth holes in it now. I assessed the situation very quickly here. Selby McRae, I talked to her husband a few days ago, and he gave me permission to use her name. Selby McRae was dead, pulseless, black, and not breathing. So I jumped in the bed with her, Baptist Hospital, Jackson, Mississippi, mouth to mouth her as best I could. Carter O'Farrell split her belly open and delivered that dead baby. Had died of hypoxia. A source of oxygen was wheeled into the room. I was able to ventilate Selby. Doodles. Doodles was her CB name. And Doodles, who was pulseless, started to have a pulse, began to pink up, and as long as I ventilated her, she adequately had a circulation and, as later proved, had no residual anoxic effects. I then, and if you will, Jeremy, you can turn on the projector. I then found that the only way that I could keep her pink was to have positive pressure oxygen continuously. That is, on inspiration, when I squeezed the bag, positive pressure, and when she exhaled, I could not allow close to atmospheric or the usual exhalatory pressure required continuous pressure on expiration. So you will see there that the bag is hooked up, After a while, she began to breathe, and then we did a tracheotomy on her, which is the next slide. And I hooked up a Farragut anesthetic machine that had, remember now, this is before Ohio and Drager started having anesthetic machines, and before we had any ventilators, and before we had any of the modern equipment that gives us continuous CO2 levels and oximetry and volumes and on and on and on. And so I was able to hook up this Farragut anesthetic machine, which had on it a water manometer that measured pressures on inspiration and expiration, and was able to adjust the exhalation valve so that when she exhaled, there was still positive pressure. To make a long story short, Shelby survived. Carter, thinking that she was dead, had sewed her back together like you do a cadaver after an autopsy, put a couple of big stitches in the uterus and a couple of big stitches in her belly wall, which required that later on we go back in and repair her uterus and repair her ventral hernia. She subsequently allowed me to take care of her when she had a cesarean section and another child. Shelby died at the age of 80 about a year ago. Now, to understand some of this, it's necessary that we review a little respiratory physiology. Oxygen in the air is approximately 20-21%. Sea level pressure, 760 millimeters of mercury pressure. 20% of that is 152 millimeters of pressure. So the Lord made us at sea level to have our good health at approximately 152 millimeters partial pressure oxygen. If we go up 18,000 feet, the pressure is half atmospheric, which means we must double the oxygen concentration to end up with 152 millimeters of pressure. The other way around, if you go down in water, you don't have to go very far before you've doubled the pressure. And thus, you don't need but half as much oxygen to get 152 millimeters partial pressure. Lungs are marvelous things that the Lord made. They just didn't develop over millions and billions and trillions of years. The Lord one day, ex nihilo, from nothing, spoke, and it happened. And the marvelous thing is, we've got 25, but we've got an area of surface in our alveoli, an area that would be 25 feet by 25 feet, all in this little small space. 300 million alveoli in you and in me. Functioning well, we're able to live, run, climb Pikes Peak. But with disease, as Shelby had, and other things that all of us as doctors put up with, we have to fall back on the reserve that we've got. Don't know how many pneumonectomies I've been in on. Would hesitate to guess. And lobectomies. Lowell Stevens, vice president of Deposit Guaranty Bank, still alive, had bullous disease so that his lung was compressed and had about a third of functioning lung tissue. So we opened him up, took out his belly, let the lungs expand, and that was when he was in his 30s, and of course he's up in his 80s now. Marvelous thing. Remember that when we breathe, pressures change. We talked about atmospheric pressure a minute ago. About to get around to talking about one of the reasons that CPAP is now used is to open the airway so that a person may breathe. We hear about sleep apnea. Well, that's a bad designation name for what we have. What happens is when a person goes to sleep and his tongue and his soft palate fall back in his oropharynx, down on his epiglottis, he obstructs. Now, I asked Claude Bard a while ago if I could use his name. Claude and I have been bunking together in hotel rooms for about 30 years. We belong to AAPS, both past presidents. We belong to DDP, Doctors for Disaster Preparedness. We belong to the Constitution Party. He and I are on the executive committee. And Claude is a horrible snorer. So much so that I would have to use earplugs. He typically would breathe a few times, snore loudly, and then obstruct. And with his obstruction, he'd still try to breathe, but nothing to go in and out. And he'd wake up and breathe 3 or 4 times and repeat it. So that when he got up in the morning, he'd worn out. Well, he now uses a CPAP machine, and he's silent. And all it does is put pressure in the upper airway and distend what would be collapsed together that would make a snore and block off. So when you hear a person talking about sleep apnea, it's not apnea in the sense that a person has too much morphine and he quits breathing and has apnea and suffocates. It's obstruction, and the apnea is caused by not being able to move air through the passageway. Well, all of us as anesthesiologists know that it's real easy to open up that passageway most of the time. All that's necessary most of the time is prognathe the mandible. And you've seen and maybe use one of the mouth guards that football players and boxers use, where the teeth recesses are such that you sleep with your mandible jutting forward, and that pulls the tongue and allows the soft palate to allow air to go in and out. Don't need a $35,000 operation in most instances, and the mutilation of the pharynx. Another way is to put a nasal airway in, which I do routinely, or an oral airway. But another way to do it is when you put the anesthetic mask on, you roll down the bottom lip, put the mask on so that the teeth are exposed, and for some reason, by golly, you can still squeeze a bag or still have a patient light enough to breathe, and they're breathing through the teeth. Under those circumstances, if you just rear the head back, tape the forehead with the head back, and that'll do it too. So you snore more and obstruct more, obviously from the mechanics with the chin down. I have never yet intubated a patient that was having a laparoscopy. We say, oh my goodness, you put all that CO2 in the belly and you're going to push the contents of the stomach out, patient's going to aspirate. Never had it happen. I've done many a gastric dissection and many a gallbladder without intubating a patient. Now, of course, when I open the chest or work in the head or work in the neck, put a tube in. But I don't have to put a tube in everybody just to show that I can do it. I'm reminded of one time that this lady was put on the operating table and had a configuration. It was difficult to see the larynx. And 30 or 45 minutes later, after trying and trying and trying to get a tube in, they did, to do a 3-minute DNC. And of course, wasn't necessary in the first place. I wrote some notes, and obviously I haven't even looked at them. And I have discussed about my dear friend Selby McRae. Well, that brings up this situation. Selby was a McRae, but her maiden name was Watkins. And her brother was Vaughn Watkins, a lawyer in Jackson, Mississippi. We did a gastric section on Vaughn for bleeding peptic ulcer. And post-op, when I intubated him to do the gastric section, there was a great big cyst on his epiglottis. I was able to get behind it, get a tube in, and woke him up before I extubated him. But when he got to the room and said, "I hurt," he got a shot of a narcotic and went to sleep, and he had sleep apnea, obstructive apnea, not due to the fact that his tongue was in the way or that his soft palate was in the way and blocked off his pharynx. His epiglottis filled his larynx. Now, I got a call that there he was, had lying in the bed, knocked out from his narcotic, and was obstructed. I'll never forget, I ran up the steps carrying my bag, jumped in the bed, put his jaw forward, put a scope in, tube in him. After a while, his narcotic level lowered, and later on, Reuben Hills MacArthur and I removed that cyst from his epiglottis. So, I have changed the text as did the preacher who had been in the penitentiary, and have gone from what's printed in the program to CPAP before CPAP. You realize that these two cases I'm talking about happened 20 years before CPAP was labeled as CPAP.